Right. This is basic chest X-ray interpretation. A disclaimer, I'm not a radiologist. I'm a respiratory care practitioner. There's a lot to know about these things, and this is just a basic aspect of a few things that we use at the bedside. So this is a bedside clinician's approach to some things that we can learn by looking at these films. Some of these things that we can learn will help direct our care. It'll help direct the modality of care. We'll go over what densities and what increases densities in the lung and outside the lung. So what we're going to do is first talk about a few things that people miss right off the bat. When you're looking at the film, what you want to do is to check the penetration of the film. You should be able to see somewhat of the spine and the spiny process of the thoracic vertebrae through the heart. Now in this particular image, you can't see that so well. So this is a shot a little bit hot, as they say. So it means everything's really light. Speaking of, the more dense the material, the lighter it is. So we have muscle, this is more dense, so it shows up lighter. You have bone, it's more dense, shows up lighter. And then you have air in the lung, is a little bit darker. So that's the penetration. And then what you want to do is find the ends of the clavicles and then see that this cervical spinous process is in the middle of those two. This patient is rotated a little bit. And what that will do is it can shift your mediastinum and make it look like it's wide or it has shifted from the left or the right. So we just need to note that penetration and whether your patient is rotated. In this particular film, we'll just go over some normal structures. The patient does have COPD, chronic obstructive pulmonary disease. What we have here is the left side of the heart, the right side of the heart, the aortic arch. You have your trachea, right main stem, left main stem, left clavicle, right clavicle, right hemidiaphragm, left hemidiaphragm, costophrenic angles here and here, which you want to see those nice crisp little arrows. And if you miss those, you could start then trying to rule out a pleural effusion, but these are nice and clean. So penetration and rotation. And so what that's going to run us into, I'm going to try to keep the lights down a little bit because the imaging is tough on the camera. What this is scattered infiltrates. This is what they're going to say. They're going to say infiltrates, bilateral infiltrates, clinical correlation recommended. Well, what we need to know is what those things are. So you can see these increased densities of the light area, and they're scattered around. I'm going to show you a way to determine what those things are and how to interact with them. So let's look at this one. This is a little bit easier to look at. So say you could see the spine, really beautiful here. That is a beautifully shot film. The clavicles are way off, but this patient is obviously in a contorted way. So we're not going to be able to use a whole lot of, hey, where's my mediastinum? But we can see that there's an increased density in the right lung. Now, what we can also see is that there is, your trachea is shifting towards it. So it's moving towards it. And so what that is, I want you to think about some things, but that's because your patient is contorted. So it can fool you a little bit. Here is the key. See these little tree branches within this infiltrate. They're kind of hard to see on here, but if you see what those are, is shadows of the tracheobronchial tree. And if you can see those within a infiltrate pattern or an increased density, what that means is that's a consolidation. So that would run me into, hey, I want to use intrapulmonary percussion ventilation, the vest, I want to improve mucociliary clearing, I want to use some kind of technique that will help mobilize secretions. So air bronchograms, those are significant for consolidation. That's the take-home message on that. Now we're going to go down here to the bottom. I want everybody to remember atelectasis sucks, okay?
Now, this is not a well-shot film. I can't see actually nothing here, and I can't even really. Looks like the patient isn't rotated very much. But what we have here is a process on the left. Not sure what that is, but what we do know is that the trachea is sucking towards it. It's getting pulled towards it. Atelectasis sucks. So what this is atelectasis of the left lung of significance. Now, there's a few things that cause atelectasis. It could be hypoventilation. If that's the case, we need to add some positive expiratory pressure, possibly CPAP, something to hyperinflate the lung. But if it's airway secretions, they can cause atelectasis. Then that means we want to shake them up. So, if your mediastinum is going towards a process, that's atelectasis or alveolar collapse. Okay? Start here. And this is an example. It's not a very well shot film. Looks like the clavicles are, he's rotated a little bit. Here's the middle of the spine. So he's rotated a little bit. He's rotated to the right. What we have here is there's something here. And I say something because that's where you need to start. But there is something here, but it almost looks like it's pushing the mediastinum. See your trachea squirm off to the right here? Well, there's something outside the lung. This is most likely a pleural fusion, and that pleural fusion is pushing things away from it. Anything outside the lung, meaning in between the pleural space, whether it's air, blood, infection, fluid, whatever it is, pushes everything in the middle away. And you could kind of see that happening here. Because here's the sternum. See this guy over here? This is your trachea. So it's getting pushed away. This is more than likely a pleural effusion, which we want to do a lateral decubitus to really determine that. And then this is more of a pattern of heart failure. This is congestive heart failure, and what this is really showing is it's not a great film. It's okay. The patient is a little rotated. They're off a little bit, but you're seeing this a highly vascularized lung here, and that is usually significant for fluid or lung water in a cardiogenic pulmonary edema. So we just kind of see this kind of cottony is sometimes, and the bat wing thing usually refers to, you can see highly congested pulmonary vessels, but I don't know that I've ever really seen the bat wing thing, but you're going to see increased congestion and fluffiness. We're going to look at just a few more images, and I'm running real fast because I don't want a video to last half an hour. Just kind of want to get to the point. This over here. Okay. In this, you can kind of see the spine there. Not really. It's a little underpenetrated. The patient is not rotated, however. Clavicles seem to be, or the spine seems to be right in the middle of the clavicles. It's decently penetrated, but these lungs are enormous. This is a good example of the flattened diaphragm and the hyperinflated lung. This is COPD. Very, very dark, tombstone-shaped lungs. And this guy is the dreaded pneumothorax. And so what you're seeing is you're seeing things get pushed away, and see how this is nice and kind of really, really dark and clear here. You can see all the nice little lines, because there's no vasculation here, there's no lung. And so what this is there's no lung markings except for right here. And that's what the lung has done. There's air that has collapsed this lung into a little ball here. So this is a pneumothorax, and guess what caused this? See this guy here? Central line. And in a patient who has COPD in the central line, this can happen. So again, here's what's left of the lung in a pneumothorax. So what did we cover? We covered a few techniques. So you should be able to determine if your film is good quality, if your patient is rotated. When you see an increased density, if there's air bronchograms or you see little shadows of like tree branches, that's a consolidation.
If you have an increased density and there's no air bronchograms and that mediastinum is sucking towards it, atelectasis sucks. In heart failure, look for increased vascularization and more fluffiness bilaterally. COPD, the lungs are going to be big. And in a pneumothorax, you're going to have a lack of lung markings. And this basic things, and there's about 1 million things you could talk about with chest x-ray interpretation, but this is just a small little segment.